Pleasure to introduce our next speaker, Gianfranco Butera, the head of Interventional Cardiology at Bambin Gesù in Rome, and formerly at Evelina. So, good morning, Gianfranco. Nice to see you again. We look forward to hearing what you have to say on complex transcatheter interventions.
Okay, probably now it's better with the audio on. Thanks a lot for your kind introduction, David, and for all the time spent together in Evelina. It was really great time for me and great way to grow for myself as a.
And thank you, Gianfranco. You never troubled me.
Thanks a lot. So thanks a lot, Aphrodite, for inviting me and all the committee. So I'm gonna share my screen with the presentation. Can you see the presentation or the slide? Okay, so I put in presentation mode. Complex transcatheter neonatal intervention. There are a lot of things that we may do right now nowadays in the cath lab that may help in the natural history or the modified history of newborns with congenital heart disease. And this is a list of what we can do in the cath lab: RVOT stenting, PDA stenting, interarterial septal stenting, some other kind of procedures sometimes are needed, or again, difficult arterioseptostomies and PDA closure in premise. But I guess that Dr. Fraser is going to deal with this last topic. Let's start with stenting RVOT. There have been some studies reporting quite not very low rate of mortality after BT, surgical BT shunt in tetralogy patients. Probably these are quite old data, but anyway, it's still a problem, in particular in some kind of diseases as PI intact ventricular septum, where also the physiology and the characteristics of the right ventricle may have a significant impact. And the mortality rate or the complication rate is much higher in patients whose weight is less than 2.5 kilograms, with the mortality rate in this paper up to 15%. Even if you can see these are data published in 2011, and probably nowadays things are a bit better. Stenting of RVOT may have a significant interest in selected groups of patients, because the stent increases the forward flow and gets systemic venous blood flow to the pulmonary arteries. So with the lower QP-QS ratio, a higher oxygen saturation may be achieved in patients with RVOT stenting compared to BT shunt subjects. So in some way can be more physiological than BT or PDA stent. Somehow pulsatile flow is provided to pulmonary arteries, increasing or improving the growth of pulmonary arteries. And usually, I mean, at least in the general experience, acute occlusion or thrombosis has not been an issue, and stent fracture is not an issue in the short term. And usually this is a palliation before surgery, and it limits the progression of tight muscular obstruction. Let's have a look, and in this paper from Oliver Stumper and his group, the mortality was lower for RVOT stent compared to the other type of BT shunts. And only the catheter reintervention rate in this initial experience was higher in RVOT stented patients compared to BT shunt. Let's have a look at some of these patients, as this one who was treated at Evelina when I was working there. You can see how tight is the RVOT in this patient. And the procedure consists in advancing a catheter right there, then a coronary guide wire, and usually coronary stent across the RVOT in order to get rid of the obstruction and increase the pulmonary blood flow to both pulmonary arteries. Again, another patient where there is a quite pulsatile RVOT. This is a 2.5 kilo patient, tetralogy of Fallot, with significant cyanosis early after birth. And what happens, and this is very interesting and important for interventional cardiologists, sometimes we are not able to cover completely with a single stent the RVOT. And as you can see in this slide, there is some an uncovered area. So there is need to cover completely the RVOT seg area in order to avoid the need for reintervention. And as in this case, where the second stent was implanted, and with a complete covering of RVOT area. And in fact, in the initial experience from Oliver Stamper, the need for intervention was mostly related to complete covering of RVOT. What are the good patients or the patients that may be elected to PDA stenting? Probably those patients where surgical risk is felt higher than standard subjects, as low weight, critically ill, with patients with isolated pulmonary blood supply, or patients where we do anticipate a short-term support to the pulmonary circulation because obviously they also grow the stent size, or patients having another percutaneous surgery. Otherwise, another option to increase the blood flow in subjects in newborns is PDA stenting, which is obviously the only option when there is only PDA supply to the pulmonary artery, as in this case, where a stent was implanted from the left subclavian artery. Sometimes it's quite easy procedure, is in this case, even if I think that it should be considered as complex neonatal intervention, in particular because we deal with low weight kids, severely ill, or with associated syndromic or genetic diseases. But sometimes it can be really very tricky, as in this case, where angiography does not really show exactly how the shape is. Usually the patients undergo a CT scan, but again, sometimes CT scan can be not completely, doesn't show everything. As in this case, where the duct was really very tortuous, we needed to put two coronary guide wires to try to advance a microcatheter across the PDA. As you can see how tortuous it is. And finally, by using two coronary wires and the microcatheter, it was possible to advance all things through the PDA. But again, it looks quite tortuous, significantly tortuous. But after the coronary and after the microcatheter is advanced into the left lung, in this case, a guide wire was advanced, everything straightened up, and it was possible to then implant a stent. This was a quite low weight kid, 1.8 kilo, where BT shunt was considered too high risk. You see the catheter, the long sheet, which is actually a femoral sheet, advanced the low, quite distal in the left pulmonary artery, and then the stent then finally in place, ready to be implanted, and a good flow to both pulmonary arteries. PDA stenting sometimes may be associated, RBOT stenting may be associated sometimes to other procedures, as in this case, where also the left PA was lost because of ductal tissue. This was a 1.6 kilo tetrahydrophilic patient I treated in Milan some years ago, but the left PA was there, and it was possible to dilate with the balloon first, and then with a small coronary artery stent. You can see how small are pulmonary arteries in this patient. This was obviously a palliation. So a coronary stent was put into the left PA, and then another stent into the RBOT. Yeah, and this is the final result, and the patient had a good palliation, and obviously with the pain of the surgeon who needed to operate on him, the patch on the LPA was needed. Another group of, I don't know how many minutes I still have, but I would like to...
You do, Gianfranco, carry on.
Okay. PDA stenting in hypoplast left heart syndrome patients is also another kind of complex procedure. This is quite, this is very well developed in London, and still an interesting option in selected the groups of patients, because otherwise the first step, the first choice is surgery, as everybody knows. Usually self-expandable stents are used to deal with the PDA in hypoplast, and this is the final angio showing nicely placed the stent across the PDA. Interventional septal stenting is also another complex procedure in the newborn, and is a kind of supportive procedure before of first stage Norwood operation. This is a small kid with a very small left PA and restrictive ASD. And you can see how is interesting the anatomy of the interatrial septal defect in hypoplast, because usually there are some attachments of the interatrial septum, and you see this white line going towards the roof of the left atrium, and this increases the difficulties of placing a stent across the interatrial septum. And again, this is quite this can be quite difficult sometimes, because the angle is really complex, or the left atrium is really small, as you can see in this case. Really a small left atrium with quite dilated pulmonary arteries, but usually, I mean, the interatrial septal stent may help in reducing the hypertension of the left atrium. In some cases, can be very difficult because of the angle. You see how angulated is the angle across the interatrial septum. This is less evident in the A view, but there is this quite acute angle, and this is a trick for interventionalists, which is quite interesting. I've been using in several cases. We do inflate a balloon across the interatrial septum, and then while deflating the balloon, we do advance the long sheet in order to help performing this very acute angle across the interatrial septal defect in hypoplast. This can be very tricky, and usually these patients are also very fragile and sometimes very ill. And finally, this is final steps after we were able to cross the septum with the stent across the septum with a nice position. There is always a debate when putting these stents between cardiologists, interventional cardiologists, cardiac surgeons, because it can be difficult to really fine-tune the size in order to obtain a good relief of the stenosis while keeping some degree of the stenosis, as you know, it's important in hypoplast. A couple of more slides on other procedures. This is a 1.8 kilo patient with a scimitar syndrome who was really very ill soon after birth because of a significant left to right shunt across the sequestration artery that we were asked to close by using plugs. The procedure is not difficult or complex in itself, but you saw how small were femoral arteries. So it was just the size, or even a bit less the size of our catheters. So we were a bit afraid of creating any issue, but the patient was really stuck and there were no other options. So I thank you for your attention. I hope that was interesting, and there will be other procedures, complex in newborns, that were dealt by Dr. Fress, I guess. Thank you.
Thank you, Gianfranco. You've obviously highlighted the fact that complexity is not necessarily the procedure, but often as much as anything related to the patient, and we're considering neonatal treatments, and so the complexity is often actually the small size and perhaps prematurity of the patient. So you've shown us how your attention has been, and your objective is to maintain patency of the duct